So today we're mainly focusing on discussing about the obstructive sleep apnea, hypopnea syndromes, risk and causality by genetics, gender, and age. So first of all, in regards to the obstructive sleep apnea, hypopnea syndrome itself, so it mainly is defined by the symptoms, which are excessive daytime sleepiness, non-restorative sleep, waking up with headaches, and daytime fatigue, and all these symptoms, along with having these episodes throughout the night, which we quantify with an AHI number. And both of these features resolve with the treatment of upper airway obstruction. So this defines the obstructive sleep apnea, hypopnea syndrome. And so these signs and symptoms are the result of the arousals we have throughout the night, and which causes instability in breathing, and the fall or the dip in oxygen saturation associated with these events, the rise of carbon dioxide levels with obstructions, and the greater in negative intrathoracic pressure that we develop when we're trying to breathe against an obstruction in the upper airway. So these factors result in the signs and symptoms as far as we know. But the impairment can be categorized into multiple facets. One is the quality of life aspect of it, where it affects your like staying awake, the capacity to stay awake, and the result of having difficulty driving, performing your work activities, and such. Also, it has medical impact, medical issues, meaning it can cause, or that's what is a mystery, but it can have an association with the metabolic syndromes, the cardiovascular diseases. It's also been associated with cancer progressions and all-cause mortality as well. But as I was saying, the relationship, the causality relationship is not very clear all the time. Is the sleep apnea causing these medical conditions, or the medical conditions causing the sleep apnea? And which may be true both ways in some of the conditions. Apart from this, there is also found to be the dose response relationship, meaning the severity of the sleep apnea kind of projects the patient's potential of developing certain conditions, which is more studied in regards to hypertension. It is found that with patients with higher severity of sleep apnea, there is higher probability of them developing a hypertension in later in life. So it seems that the severity of sleep apnea is important in knowing the prognosis of the patient. But more importantly, what, the most of the studies so far have studied the impacts, the AHI, the cyclical oxygen desaturations, those things causing the disease comorbidities. But how does a patient get to that point, meaning their severity of sleep apnea? And that's what we are trying to explore by at least three mechanisms, which is genetics, gender, and age. But before we dwell into discussing about those factors, how they impact, we need to know how what are the uh, causality for the expression of the apnea events, meaning how does a person have more apneic events throughout the night, and what are the factors that predispose them for that in terms of their ventilation, the anatomy, and all. So these factors can be broadly divided into four different categories. So the first one is the threshold for arousal from sleep, which we're going to discuss a little bit more in the next few slides. So the four factors is the threshold to arousal. The second one is critical closing pressure, which is used as a surrogate for like how the anatomy of your respiratory system is. And the third one is recruitment of the muscles, how the muscles respond to these breathing disturbances through the sleep. Finally, the loop gain, which is the ventilatory response after the cessation of an breathing act or apneic event. So the first one is arousal threshold. So in regards to breathing instability, so the sleep itself is a risk factor for sleep apnea. So if nobody sleeps, nobody has sleep apnea. And how this sleep causes an increased risk for sleep apnea is by two main mechanisms, which is the reduced ventilatory drive when you're sleeping and the change in state of your sleep or the arousals, which helps in termination of the events. But at the same time, when it's trying to terminate the event, it makes your airway system a little bit more fragile in terms of having a next apneic event. So if the patient, as I said, if the patient has lower threshold, as you can see here, lower threshold for arousal, their instability is higher, or the propensity for them having a next event is higher. The thought is if the patient is able to stay asleep for a little bit longer, or the threshold for their arousal is a little bit higher, their chemo or mechanoreflexes will kick in and help maintain the patency of the airway. But if they have low threshold, before they can kick in, they are just waking up and producing more instability in their breathing. And you can imagine with each person having different reflexes, the intensity of these reflexes, there's variation in sleep apnea expression as well. We can, as I said, the chemo response, so these reflexes, not only between persons, but also within the stages of sleep, the chemo responsiveness is also different. For example, in non-REM stage of sleep, the chemoresponsiveness is lower than wakefulness, which causes instability in breathing, which even further worsens in REM stage of sleep. So that's why you tend to have more and more AHI as you go into non-REM and REM sleep, because the reflex responses are a little bit sluggish. The next factor is a critical closing pressure. As I said, it's a surrogate for how your upper airway anatomy is. So if the factors which can affect the closing pressure are, if you're obese, there's high positive closing pressure. There is a probability of inflammation causing the increase. There's edema that can increase this, and trauma to the tissues. And edema also, that's one of the factors where you see when people are in prone position, they tend to have more, especially in patients who have edema already. They tend to accumulate more in their upper airways and have more instability in their breathing. And CPAP's main function is to counteract this critical closing pressure. So that's how it's helping us not have these events. And the third point is recruitment of muscles. So whenever you have this disturbance, you need to have these muscles respond to it and activate and keep the airway more stable. In the picture you see here, the darker line is when the patient is having an event. The lighter line is where it's ideal response. So in patients with sleep apnea, some of them at least have, so the top one is called moving time average electromyogram. It just is saying that in regards to your chest wall movement, how is your upper airway moving? So that's the response it's calculating. The EMG raw is just the raw data of the the pharyngeal muscles responding to the events. So as the epiglottic pressure increases, the response of those muscles should increase. But in patients with sleep apnea, the recruitment of these muscles is low, thus increasing the number of events. And as you can imagine, the weight or more edema in those muscles, there's more tone that is needed. So there is more potential for them to develop these events. And the last one is the loop gain. The loop gain is a phenomenon where your ventilatory drive is trying to get back to its steady state, but it overshoots sometimes. The more the person has a propensity to overshoot the response, the higher the probability of that person having an event at the other end of it. So overall, if there's high loop gain, they have high probability of developing recurrent apneic events. Um, all right, now that we understand those phenotypic characters, the four things, um, the critical closing pressure, the arousal threshold, the muscle responsiveness, and high loop gain, we'll explore more about the genetics and how these genetics, gender, and age, and how these factors affect those four characteristics, which can increase the severity of sleep apnea, so to speak. So first, speaking about genetics, we all know each and every characteristics of our body is defined by or produced by a particular set of genes. And we can imagine the factors that are affecting AHI, like airway anatomy, body habitus, respiratory control, all of these have a gene for them. But most of the studies just focus on the later part, like the easier physiological characteristics, meaning the oxygen saturation drops, the AHI itself, rather than the gene or the causality part of it. Mainly because it's very difficult to assess this, mainly for two reasons. One, it's hard to find one gene that can have like a big effect on the breathing itself. Also, there is cumulative effect, meaning there are multiple genes that can have a small effect and they can cumulatively impact that event rates. So it's hard to pin down those genes or have a discussion about that in that level. But most of the genetic um, abnormalities that we know right now is mostly from the congenital abnormalities we know. So we had congenital abnormalities for children. We studied them. They had these breathing difficult or sleep apnea later in life. And then we went back and said, hey, are all these patients with these genetic abnormalities having the sleep apnea? And that's how we found some of the genes found in kids. So the parents of the kids who had these genes or expression of the genes who were found to have sleep apnea, their parents also were found to have sleep apnea. So there is probably that genetic effect, but again, it's hard to study. So again, going back to those four characteristics, the critical closing pressure, gain, muscle response, and all that, these are some of the syndromes that can affect all those factors. As you can see, the first one is the sleep itself, but the second one, the anatomy. So these syndromes can have the anatomical abnormalities which predispose them for having instability in breathing during sleep. In some of these conditions, we can immediately find out, okay, this patient's probably has sleep apnea, they need to be treated. But some of these conditions, they don't have sleep apnea initially, but they can develop sleep apnea as their age progresses. The other conditions like congenital central hypoventilation syndrome. So these conditions have the loop gain effect more, and conditions like spinocerebellar ataxia, myotonic dystrophies, these have effect on their muscle recruitment. And there are certain conditions which can affect all of these features. So we'll focus on a few of these conditions. The first one is PHOX2B. It's also called paired like Homeobox 2B mutation. So these mutations, the patients with these mutations have a rare dysautonomia, meaning they have the central hypoventilation syndrome more. And they have more tendency to have respiratory arrest during sleep. And they also have occasionally these episodes during when they're awake as well. Then, um, then there are certain conditions, again, Peri-Robin, Prader-Willi, Down syndrome. Uh, the genetic detection, the genetic abnormality is detected early, but their presentation to sleep apnea could be a little bit later in life. Again, this is another example for hypoventilation effect syndrome in Pompe's disease. And finally, Ehlers-Danlos syndrome. Ehlers-Danlos syndrome, there are certain patients who do not have the diagnosis of it until later in life. So their diagnosis for sleep apnea also gets delayed if they have it. So that's kind of genetic impact. So we'll have to be mindful whenever we're thinking about these genetic abnormalities. Do they have sleep-related breathing disorders, and how early we should be considering to monitor for those? Um, the next discussion is about gender and transgender. So in regards to gender, we'll talk about between gender, men and women, and within gender, uh, premenopausal, postmenopausal. And also we'll touch on the transgender population as well. So in regards to gender itself, we know that in premenopausal women, at least, aged less than 50 or so, um, the overall AHI is less in women than men, uh, but they tend to have more of insomnia pictures. They have more restless leg symptoms, which confuses or makes it difficult for recognition of sleep apnea itself and the management of it. And the other factor is women tend to have, along with these comorbidities, they tend to respond better meaning in at least in terms of insomnia, meaning when we find these patients with sleep apnea who are having insomnia, and when we treat both men and women tend to respond better for treatment than men in resolution of the symptoms. So this tells us that there's probably some hormonal effect. Well, there is always the chance for behavioral tendencies too, but there probably is hormonal effect. And hormones, by and large, again, there are some genes that can affect these hormone and hormone expression, and when and how they're expressed, meaning premenopausal women to menopausal women, even in premenopausal women, between menstrual cycles and during menstrual cycles, the hormonal differences. Um, when we talk about menopause, there is natural menopause and surgical, meaning surgical removal of ovaries. So is there a difference between these two menopauses? Because we're just saying maybe the hormone is what is causing it. There seems to be a difference. The surgical menopause, the patients with surgical menopause tend to have a higher hazard ratio for sleep apnea by a study. So it's not just the lack of hormones, but how you get there is also seen to be an important factor. Um, and again, we just discussed about like women having overall lower AHI than men in premenopausal stage. But when they do have sleep apnea or apneic events, they tend to be more in REM stage of sleep, where the the muscle tone is lower. A 2019 study showed that keeping all the factors same, Women tend to express more of these events when their muscle tone is lowest. So that's REM stage of sleep. So that's what they found to have like high REM stage sleep apnea. And another condition where the hormone abnormalities are found is a PCOS. But all the studies so far is not very clear how it affects. It's thought to be bidirectional interaction, and meaning the sleep apnea causing metabolic disturbances and thus causing more of PCOS symptoms, and again the other way too. So if hormones have so much impact on sleep apnea, would would supplementing hormones, especially in postmenopausal women, where we know the risk kind of matches with men after the severity of sleep apnea in regards to severity of sleep apnea after menopause. So does it mean that postmenopausal women, if we just give them some hormones, will they be better protected since it's better in premenopausal stage? There have been studies that looked into this. The first study looked into this did show some benefit. They gave estrogen and progesterone, and they found that there was a significant reduction. The severity, the AHI kind of dropped from 15 to about 3, plus or minus 1. So there was a significant improvement. But when they tried to replicate this in other studies, it wasn't successful. There was another study where they just gave estrogen and found that there was a 50% reduction in AHI. So estrogen monotherapy seems to be equally helpful too. So what they thought, okay, if this amount of the normal amount of estrogen is helping so much, can we double the estrogen supplementation and have a double the effect? Not so much. So when they looked into that study where they doubled the estrogen supplementation, the change was very small, but on the contrary, they developed more REM stage sleep apnea or AHI. So just supplementing hormones doesn't seem to be a solution here. Well, they studied these hormones. They did like a short-term studies. Should we have done for a long time, long duration supplementation or a different formulations or a targeted hormone where it affects the brainstem rather than all the bodily organs? That needs to be studied. Oh, I skipped that suppression part. They also try to see if we suppress these hormones, does that increase the sleep apnea intensity? So in one of the studies, they gave leuprolide acetate, which is a gonadotropin releasing hormone, which just decreases the production of estrogen and progesterone. When they did that study, they found that women tend to have more snoring, but it did not actually affect the arousal index or sleep fragmentation or AHI. All these were not affected, just they snored more. So the suppression did not replicate the production of sleep apnea as well. And finally, the transgender part of it. There's very less research in so far on this topic. There are mouse studies where so does transgender have an effect in their sleep? The mouse study showed the sleep deprivation when they did induced sleep deprivation and compared phenotypic female who had XX and XY, the sleep, the rebound sleep was more in XY category, and they had higher non-REM or delta sleep rebound as well. So that's one study. And the second one is a case series that was reported where a transgender woman born male, the chromosomal male at birth, was found to have resolution of symptoms of sleep apnea symptoms uh, after the transition. And in transgender male who had chromosomal female at birth, started to develop obstructive OSAH syndrome after the transition. So, well, there is hormonal effect. It looks like there is a hormonal effect, but I think we need to better target these therapies if we are thinking about these therapies in order to have an outcome that is favorable in terms of controlling the sleep apnea itself. And finally, um, we are going to talk about age and ageism. This is interesting. And always thinking about this, but here we go. Uh, so age is just the chronological, like a calendar year. But how does your body know? It's like, oh, now I'm 45. My risk needs to increase. Does it switch the anatomy? Or is it a gradual process? Most of the studies have found that so there's two categories which is more clear, right? One the earlier age groups where between 2 to 8 and adolescents, they tend to have increased disordered breathing. But from then to beyond fifth decade or beyond 50 years of age, where again, the risk increases every 5 years. But between these age groups, it's not very clear, or there's little data in terms of how the risk progresses in terms with their age. And I bring the survivor effect to say that after age of 65 or so, the, the sleep apnea severity kind of, so from 50 to 65, it increases increments of 5 years, and then it plateaus. One of the things that might be causing this is the survivor effect. So probably the patients are not alive beyond that age where we can study, okay, they're continuing to increase their severity with age. So they probably is that survivor effect. Um, so, so when we look at the AHI, we just have the standard categories 5 to 15, 15 to 30, and beyond 30. But with age, there are so many changes that occur with your anatomy and all the physiology, the ventilation itself. So all this happens, but we just tend to use the same criteria for the younger age group versus the older age population. So it begs the question: should the normal range be different for them? Um, and this was a great discussion last week, I think, with cardiovascular diseases. Should we treat everybody with mild and moderate? If that is a natural progression of these patients, right? As you grow older, are you supposed to have a little bit more or a little bit higher threshold to start treating? Well, so far we are just following the Medicare guidelines for CPAP treatment. If mild to moderate with symptoms, we'll treat with CPAP, and greater than mild symptoms with symptom mild degree of sleep apnea with symptoms, we go ahead and treat. And then also in patients with greater than 15 events, that is moderate and severe sleep apnea, regardless of symptoms, we tend to treat them. This is from the Medicare guidelines that we follow so far. Then, so how does this age affect the ventilatory control? It could be from various multiple levels. Again, as we know, there are different factors. We talked about the critical closing pressure, loop gain, and all this. So that the age itself might be having an effect on those, which we'll discuss in a little bit, which are potentially causing this sleep apnea. And then so there are two models, the causal and amplifier model. So Is it the cellular and molecular impairment is causing it or amplifying the already sleep apnea? Is kind of a bigger discussion. Some of the particular diseases which are more common and as you grow older, the stroke seems to be a moderate risk factor for sleep apnea. And so every person who has stroke, we are now tending to look for sleep apnea. However, on the back end, do we treat for sleep apnea and does that decrease the incidence of stroke? Um, Not so much. And in the same way, the dementia as well. As you grow older, the dementia risk increases, and also the sleep apnea risk increases. Does the sleep apnea, treating that will help dementia? That's also up for discussion still. And this is the final, the theme, as we are talking about those four factors and how uh, these three variables affecting those four factors, which can have increase the recurrence of sleep apneic events. The first one is anatomic pathway or the critical closing pressure. As you grow older, the pharyngeal muscle, the fat increases, and that increases the critical pressure and thus worsening the sleep apnea potentially. In regards to the sleep itself, we know that as you grow older, the propensity to spontaneously wake up from sleep increases. And if you remember the first discussion we had, the lower the threshold for sleep, the lower the threshold for arousal, the higher the chance that you are having those respiratory instability causing sleep apneic events. So overall, as you grow older, the arousals increase and thus the possibly increasing the possibility of having sleep apnea. Third one is muscle recruitment. As you grow older, the response of the genioglossus muscle and other muscles to respond decreases, it blunts. So that can increase the severity of sleep apnea as well. And finally, the chemical control of breathing, the gain pathway, uh, this also becomes more unstable. The chemo reflexes tend to be not function as well, or they're more unstable, causing more of these events. So overall, we can see how the age, the gender with the hormonal effect, and genetics with expression of their phenotypes, the genetic abnormalities expression, can have effect on obstructive sleep apnea. And so this begs a question that, well, do we need to think about other modalities of treatment rather than just always focusing on just keeping the airway open? So with that, I end my presentation and it's open for discussion. Thank you. And as I was saying before the presentation, Dr. Stroll suggested this wonderful presentation. Thank you. So any questions about that?